Hi everyone, I am back. I was talking to Dr. Rich and our connection looks like it kind of went off. So again, um, okay, there we go.
Okay.
Um,
Sorry, I'm not sure
I'm
why
not
we're
sure
having
what
these
happened.
technical difficulties.
Okay, can you hear me and see me now?
Yes, I can hear you and see you.
Okay.
Can you?
Yes, you are cutting in and out a little bit. You are cutting in and out a little bit, but maybe
Okay,
okay.
yeah,
Yes,
there is
okay,
a
I can
little
I
bit
can
of
hear
a
you now. It
delay
looks
and
like
some
it's
cut out.
a bit choppy for whatever reason. Is there another spot maybe you could move to? Jessica, I totally cannot hear you. Um, okay, I lost my guest, but I am going to re-invite her. I think she is in a spot with bad reception. Okay, that's better, I think. Okay, I can hear you. I can see you.
Yeah, I'm not. This is usually a place of pretty good reception, but let me see if I can move around a little bit if this isn't working.
Okay, now I can hear you, but it still seems like it's kind of a little choppy. Okay, that I think is good right there. Okay.
Okay, let's try this, and if I have to move, I'll even go outside if we need to see if we can
Sounds good.
get a little better reception.
I think we've hit a good spot. Okay. So we were just talking about kind of what kinds of things you do currently as a minimally invasive gynecologist, and what your daily practice looks like.
Yeah, so I'm in South Florida in the kind of Miami, Fort Lauderdale area, and I do focus on minimally invasive gynecology. So I see a lot of women with abnormal bleeding, with pelvic pain, with fibroids and endometriosis, and then some more sort of routine stuff like cysts and routine exams and PCOS. Those are kind of the main areas that I specialize in. I'm in a private practice with a urogynecologist, so she does a lot more of the urinary symptoms and pelvic floor physical helpful. This looks like.
Oh, you know what? I think we are your connection. The connection is back again. Jessica, can you hear me? Oh man, I think okay, you know what? I we didn't hear most of that. Is there another spot you could maybe move to, even if it is outside? Totally fine, as long as we can hear you. We don't want to miss all the important stuff you're saying. Oh man. Okay, let's see. Okay, we're gonna try this again. Hopefully, Jessica has moved to a spot outside. I think she has bad connection. Okay.
Okay. I moved outside. Hopefully this
Okay.
is a little bit better.
Yes, third time.
I'm not sure what's going on. Usually the reception is really good where I was set up, so I don't know what's going on today.
Okay, now I can totally I can see you and hear you well now. So this should work. Thank you. So actually we didn't hear most of what you said, but you started out by saying that you're kind of doing fibroids, PCOS, endometriosis, and your partner in your practice is your gynecologist. And then that's kind of where we stopped.
Right. So she sees a lot of the sort of urologic issues like urinary symptoms and prolapse. And then we have a couple of great pelvic floor physical therapists in our practice and a few great nurse practitioners and physician assistants. So it's really a nice comprehensive practice where we can deal with benign gynecologic conditions. We don't do any pregnancy stuff other than the caring for women after pregnancy or in support before pregnancy. But it's a really great kind of practice. So that's where I am.
That's awesome. So today we're, as you know, and as our listeners probably know, July is Fibroid Awareness Month. So every week this month we've been tackling a different sort of topic about fibroids and either treatment or other statistics about fibroids and more information about it. And so this week we're going to talk about ablative treatments like the ACESSA, Sonata, and a little bit about uterine artery embolization or fibroid embolization. So I would love to hear from you, what makes you think about these options for patients? Because as we know, for treatments, there's so many. There's, hormonal treatments, and there are these ablative treatments. There's myomectomy, there's hysterectomy, there's, lifestyle, food, and modifications. So in this broad spectrum of treatment options, what kinds of patients do you think about, or do you, when you see them, you think about, okay, maybe they're a good candidate for ablative procedures?
Right. Yeah, you're absolutely right. There are so many treatments out there, which I think is really great because I don't think any sort of condition is really a one size fits all approach. So I like to have different options out there. And my general approach, of course, is, I like to talk to women and see what their symptoms are and what they're feeling. And then also kind of what their objectives are in life. Is it something where they want to have a pregnancy in the future? Is it something they're having bleeding symptoms or bulk symptoms, or, what are their symptoms like? How aggressive do they want to be? What are their plans for the future? Those are the main things that I start to think about. And then the size and the location of the fibroids, of course, is really important too, to look at those treatment options. I tend to think of ablative options for women, of course, women who have completed their childbearing. So these aren't really good options for women who want to get pregnant in the future. While there are some case reports for many of the different options of pregnancy and sometimes successful pregnancy, there's really not a lot of good data on any of them as being sort of safe for pregnancy in the future. They tend to have more, at least more risk of complications for pregnancy in the future. So these are really options for women who don't want to get pregnant in the future. The size and the number of the fibroids and the location of fibroids is important too. Most of the ablative options are going to be better for fibroids that are intramural, so in the muscle of the fibroids, sometimes submucosal as well, and some of the subserosal or on the outside of the uterus, but not really the pedunculated fibroids. Those really don't get treated well with ablative options. So there can be a combination of location, but really the sort of number, location, and size of fibroids is just as important as the symptoms and the goals that the women are having.
Great. So that's a lot of factors to think about.
Yeah.
Kind of a holistic picture, because there's a lot that can go on and a lot that can influence your final decision on treatment plan along with the treatment. So tell us a little bit about the ACESSA procedure, ACESSA, and kind of like, how is it done? And where is it done? Is it in the office? Is it in the hospital?
Yeah, so the ACESSA procedure is one that I don't have as much experience actually doing, and I'll tell you why. But it's something that I think I'm gonna probably be doing a little bit more of in the future. It's done in the operating room. It's typically a procedure that's done laparoscopically, and basically what it involves is using an ultrasound device through a laparoscopic port, and using a device that's a radio frequency ablation. So that's the kind of energy that's going to ablate the fibroid, and that's all going to go in through laparoscopic ports. typically done in a surgery center or a hospital, typically a procedure that's outpatient, so you can go home the same day. Usually takes about an hour to an hour and a half, depending on how many fibroids are going to be treated. And the recovery is pretty quick. You know, there can, of course, be some pain and some downtime with it, but it's typically going to be less than a more invasive surgical approach. The reason why it hadn't really been something that I was too excited about previously was because I thought, well, if I'm going to go in laparoscopically, I might as well just take out the fibroids or do a laparoscopic myomectomy. And I do think that that's, you know, a good approach for still most women. But what the benefits of the ACESSA are a couple. One of them is the blood loss. So as you know, fibroids are in the muscle of the uterus, and that can cause a lot of bleeding. And even though we have techniques to reduce that bleeding, when we're doing a myomectomy, there's still pretty significant blood loss with that type of surgery. So especially if somebody's already anemic because they're having such heavy periods, that blood loss can increase the risk of things like blood transfusions and other complications. So with the Sonata, with the ACESSA, we're not really seeing a lot of blood loss risk. The other thing is, you know, with changes that have happened in, you know, the last decade or so in terms of morcellation devices and avoiding that, with bigger fibroids, there still sometimes has to be a slightly larger incision to remove those fibroids, again, depending on the size of the fibroid and the approach. And so what's nice about the ACESSA as well is it keeps those port sizes small, typically about 1 centimeter or less, and smaller incisions mean less pain and faster recovery time.
Yeah, that's great. And typically, you know, how, what size, what's the kind of upper limit that you would say you would deal with this, you know, with this procedure?
Yeah, so typically it's going to be about 6 centimeters, but it is something where you can treat a fibroid that's larger than that with multiple different areas of ablation. So sometimes you can get into those bigger fibroids. It really just depends on how that fibroid is big. So if you have like a very big round fibroid, sometimes it can be hard to get the treatments exactly where you need them. Whereas if it's like maybe a little bit larger in one dimension, but in the other dimension, it's closer to that 6 centimeters or less, then you can get a little bit better of a treatment option there.
Great. And any other than, you know, it's a laparoscopic procedure, so certainly we talk to patients about complications of laparoscopy, but other than that, any special other additional considerations that a patient needs to think about when they want to do this procedure?
Right. So in addition to the typical, you know, laparoscopic treatment options or procedure sort of risk factors, there can be a little bit more pain to these procedures afterwards while the fibroid is degenerating. Basically, we're kind of like killing off that blood supply to the fibroid, and that can cause degeneration of the fibroid, which is what we want. We want the fibroid to shrink, but during that process, there can be some pain and there can be some infection that goes along with that, although those risks are quite low.
Okay.
And again, we don't want pregnancy after these procedures.
Yeah, so that's a really important point because a lot of patients who are getting these procedures are young and are delaying fertility even to their late 30s or early 40s. That's something to think about and know. Not that you absolutely cannot, but there's just very little data. And so if you can avoid it, it's best not to get pregnant after any of these ablative devices because essentially there could be some compromise of flow to the uterine wall. Now, after the ACESSA procedure, do these fibroids, can they grow back?
So we don't tend to see a lot of growth of the fibroids that were treated. It depends, again, a little bit on that treatment area. So if you have a larger fibroid that wasn't completely treated, then there can be some regrowth. Typically, we're finding that with most ablative procedures, that if you treat at least 50% of the fibroid, so even just half of the fibroid, that's typically enough to kind of disrupt that blood supply to the fibroid enough that you're not going to see regrowth. You may see stability. It might not get a lot smaller after a certain point, but it shouldn't regrow. But just like any other treatment for fibroids, aside from hysterectomy, there is a risk of recurrence of additional fibroids that haven't been treated with the initial procedure. So there's always that risk.
Right. Okay.
Mm-hmm.
Yeah, this is a procedure that we were, I think first came out when I was in residency and we were trialing it. And then somehow, it's getting reintroduced into our hospital right now, in
Mm-hmm.
California. But not every center actually has this, and not every hospital has it, and not every group has it. So if this is something
Right.
that you're, interested in as a patient, it's something that you specifically want to ask about as well. Um,
Right. Some of these newer ablative procedures, if it's something that you want, it's worth going to the website for the company to see, what are the providers in your area that might provide it. Because again, it's not available anywhere. Anytime there's a new device, there has to be permissions to get it into a hospital or a surgery center. There has to be training for the doctors on how to use it. So I usually recommend checking the company's website to consult with a doctor if you're interested in that procedure.
yeah, that's a really good point. So let's move on to the Sonata device.
Mm-hmm.
I'm excited to hear about this because we haven't used this, and I think it's starting to again be introduced into our hospital. But as you mentioned, it's a big process to introduce new machines and technology,
Mm-hmm.
and so I'm excited to get on this. But tell us a little bit about how this is different than ACESSA procedure.
Yeah, so the Sonata is one that I have a lot more experience with, and that's because I think there are a lot of things about it that are very appealing. So this is a procedure where we take a device that has an ultrasound on the end of the device. It goes through the vagina, through the cervix, into the uterus, and within the uterus, then we can use the ultrasound to find those fibroids. Once the fibroids are located, then I deploy these electrodes into the fibroid itself. And again, it uses radio frequency energy, so similar energy source to the ACESSA. But the benefit of this is there's no incisions. So because we're going through the vagina, through the cervix, there's no incisions, none of those sort of laparoscopic risks that we talked about. And I think it's a really great option. It's a similar approach in the sense that it's sort of shrinking the fibroids and decreasing the blood loss. It has pretty high success rates, pretty high satisfaction rates. The size of the fibroids that we're treating with this are anywhere from 1 centimeter to 6 centimeters. And again, I have treated some that are a little bit larger, but it really depends on how that size goes. So if it's a fibroid that's larger, but kind of pushing away or out of the uterus, that's a little bit harder just to reach because from the inside of the uterus, you can only reach so far. So while we can treat intramural and submucosal and some subserosal fibroids with this, I find that it's less effective for the subserosal and less effective for larger fibroids that are pushing further towards the outside of the uterus.
That makes sense because you're putting
Mm-hmm.
the probe inside, inside the
Mm-hmm.
cavity. So that answers a question that somebody had asked when we actually posted the little flyer for this live as to what fibroids are best treated with this procedure. And it's really the
Mm-hmm.
submucosal ones and the intramural ones because they are closer to your probe, essentially, versus the other ones. So
Mm-hmm.
that's great. Now, is this something you do in the office?
It's something that can be done in the office. In the original trials, some of the people in the original trials did do it in the office. Usually those are people who have like sedation services that come into their office. I don't do that in my office. We have a few options for pain management, but I find that, particularly if we're treating multiple fibroids and if somebody hasn't had vaginal deliveries before, it can be a little bit too uncomfortable. So I usually do this in a surgery center. Usually under either monitored anesthesia care, so like a strong sedation, or under like a light general anesthesia, so like an LMA rather than like a intubation. The timing of it really depends on how big and how many fibroids. So while if it's like one fibroid that's maybe like 3 to 4 centimeters, it can be pretty quick, like 15 minutes or so. If you're treating multiple fibroids, sometimes this can take an hour, hour and a half, depending on, that size and how many treatments that you're going to do.
Okay. And you can kind of see it shrink away with your ultrasound, right? So
Well, it doesn't necessarily like shrink on the spot, but you can see where the treatment is. And what's nice about it is it does actually heat the tissue. So
uh-huh.
if I'm unclear if I've treated a specific area, then I can kind of redeploy in that area and measure the temperature of the tissue and see if that's an area that I've treated. And you kind of can see the changes on the ultrasound as they go. So it gets a little brighter white as that ablation happens. You know, you asked about who's a good candidate. The other group that I really like this for is for the adenomyomas. So actually, the first patient that I treated with the Sonata was a patient who had an adenomyoma, so that fibroid with those glandular components. And these are kind of notoriously hard to treat with myomectomy. They don't have good planes. They tend to have a little bit more bleeding. But it responded really, really well to the Sonata treatment. This patient was like already had visible difference in the size of her uterus, and she could feel a difference by 2 weeks
Oh,
afterwards when I saw her. She was like running, going for a jog, like within 3 days of the procedure. So I really like how it's been with that. And I've had a few other patients with adenomyomas that I've treated since then that I think it's been really helpful for.
that's great because those are hard to treat.
Yes.
Without hysterectomy sometimes as the final option. They don't really respond, as you said, to myomectomy, the poor planes. So that's a really good tip for those with adenomyosis. And this is also same day, right? The patients go home the same day, and very little really in terms of recovery,
Right.
and recurrence probably similar to the exercise.
Right. Similar. As long as you're treating at least 50% or more of that fibroid, we don't tend to see regrowth of that particular fibroid. As with the others, you can still grow new fibroids. And as
Sure.
with the others, I don't recommend having pregnancy afterwards, although they do have a few reported cases of successful pregnancy. There's still too little data to say that that's safe. What's also nice is that because we're doing a hysteroscopic procedure, you know, at the same time, if there are submucosal fibroids to remove, that can be done. I also tend to do endometrial ablations at the same time of this procedure too, just as another way to kind of further reduce the bleeding for women who are having a lot of bleeding issues with their fibroids.
Yeah, that's great. What type of ablation do you typically use?
So I typically use the NovaSure if it's going to fit in the cavity.
Yeah.
Otherwise, I tend to do like a hand ablation with a roller ball.
Okay. Great.
Mm-hmm.
Awesome. Um, Good. And then let's move on to embolization, which I think is the mother of all ablative procedures, sort of.
Mm-hmm.
Now these are typically done by a radiologist, an interventional radiologist. So talk to us about which patients you particularly feel like really benefit from an embolization versus one of the previous ablative procedures we just discussed.
Right. So the ablative procedures we just discussed are relatively new, but you're absolutely right. The uterine artery embolization is the one that's been around for the longest. And this is a great option for a lot of women, again, women who do not want pregnancy in the
Yeah.
future. This is a procedure where the interventional radiologist will go in, usually through the blood vessels in the groin, which connect to the blood vessels in the uterus. And they put in these little, I like to think of them as beads. That's not really what they are. These are sort of little embolization pieces that kind of cut off the blood supply or reduce the blood supply to the uterus and therefore to the fibroids. And those will typically cause shrinkage of the fibroid by about 30 to 60%, which can make a big difference in symptoms. So it's helpful for bleeding symptoms, helpful for bulk symptoms. And so again, I usually tend to think of these in women who don't want further pregnancy, but don't want a hysterectomy, either tried and failed hormonal options or just had side effects or don't want hormonal options for whatever reason. I think this is a great option. Just like with the other procedures we talked about, there can be some pain while the fibroids are kind of shrinking or going through that necrosis process. There can be infections afterwards, but in general, the risks are quite low, and it's a great procedure. It's not perfect, just like anything else. About a quarter of women will end up going through a hysterectomy, in 5 years or so after uterine artery embolization. But it's a great option to potentially avoid that more invasive procedure, or if you are not in a point in your life where you can go through the more definitive procedure, then it's a good way to reduce symptoms in the meantime.
Yeah, great. So what percent of women do you think opt for an embolization?
Yeah, it really depends. I would say I definitely had more embolizations before we had some of these other options available, like the Sonata. But I would say it's actually less frequent. I think, you know, I don't know the data overall of the percentage, but in my practice, and I think this may just be that they're coming to me for specific procedures, but in my
Yeah.
practice, most women are either at a point where they want pregnancy in the future, in which case we're treating either with myomectomy or with options to control their bleeding medically, or they're like done with it and really want to be done with it and they're looking for a hysterectomy. So while I do have women who want the ablative options, and like I said, we've been doing more of these procedures, it's a smaller percentage who are going for the uterine artery embolization. Now, again, that might be because they're seeing the interventional radiologist first before they're seeing me, but I would say less than 5% are opting for that in my practice.
Yeah, I also find the same thing. Very few women are going for that. I think it's a particularly good option if you are otherwise a poor surgical candidate. So you've
Mm-hmm.
had multiple previous surgeries, you have a lot of scar
Right.
tissue, you've got other things, other medical conditions that, you know, which, preclude you from undergoing general anesthesia. So those are
Definitely.
who then prefer this because they don't have to have their abdomen opened and go under general anesthesia. So
Mm-hmm.
that's a patient population that often opts for it. Yeah, but I agree. For whatever reason, it's like about less than 5%.
Mm-hmm.
Go for it. But yeah, it definitely reduces the bulk symptoms, and some patients do. The patients who've done it do complain of some pain afterwards, as the fibroids sort of everything, the material gets out and kind
Mm-hmm.
of degenerating. Um, but for those who are interested in that procedure, Fibroid Free MD on Instagram, Dr. Slonim and Reddy really are specialists in this procedure. They're out of Dallas, so definitely check them out. They are pros at this, and this is all they do. So that's a good resource as well. So awesome. So we really talked about three really different procedures,
Mm-hmm.
completely different actually, that can all be used to treat fibroids. And other than embolization, we've talked about how these are fairly new procedures, and certainly not all hospitals may be doing them, not all doctors, not all fibroid centers.
Mm-hmm.
Even. So if you as a patient are interested in this, make sure you do a little homework prior to seeing a particular gynecologist, because you may wait for 3-4 months for an appointment and then find out that they don't actually even do the
Right.
procedures.
Definitely not all gynecologists do that. And then the one that I would add to that too is the high intensity, either ultrasound or the MRI
Oh,
related ablations. And those are really a great option too for women who don't want to go through a more invasive approach. Again, not for people who want pregnancy, but this is where they basically focus energy from externally in the body through ultrasound or through MRI at the fibroids. And these tend to have a little less pain than some of the, like the uterine artery embolization, but they're also a little bit less effective. So more chance at needing another procedure afterwards. Those are usually focused on the bigger sort of academic centers. Many of them are still kind of in experimental trials. So if you're reading about that and you're interested, that's another one that's really important to make sure that there's somebody in your area that can actually offer that.
yeah, that's totally right. I think there's only one center in all of Northern California that I know
Mm-hmm.
offers it. And yeah, I don't
I
think,
don't even know of one in my area, to be honest with
yeah, I
you,
don't
but
think
it's something we did in fellowship a little bit.
that's right. And
Mm-hmm.
technology is always changing. There's so many new things that are coming up. So, which is great, because fibroids are one of those things that I feel like plague women, right? 80 to 90
Mm-hmm.
women are even diagnosed with a fibroid by the time they're 50, 55, disproportionately affecting women of color as well. So this is a huge um, burden of, disease essentially for women. So more options are good, and it's great to be armed with all the knowledge that we can get so we can get treated well. So uh,
Definitely.
wonderful. Anything else you'd like to add about any of these procedures or fibroid treatment in general that you've discovered in your practice, or that do in Florida?
Yeah, I would say the only thing is just to reiterate what you said, that there are so many options out there. And I think the biggest problem that I see is that I have women who luckily find me for a second opinion, who have gone to their doctors and they've been told, well, you just need a hysterectomy. This even happened to me last week with a 24-year-old patient who wants to have a family and didn't have any children at that point. And so just to make sure that you know that there are options out there, there's several of the options. And if you're not getting that information from the person that you're seeing, then a minimally invasive gynecologist is typically the best person to see for this. Just like you and I, we're trained in all of the different things that are available and can help you find the treatment that's going to be best for you.
Yeah, that is such an important point, such an important point. Really advocating for yourself and knowing that there are
Mm-hmm.
treatments, and absolutely that hysterectomy is not the only way to go. Some of our parents and grandparents and aunts have been told that, right? But certainly we don't have to buy into that. So
Right.
awesome. Well, thank you so much for joining me today and for all this great information. I certainly learned a lot myself. So I hope our listeners and viewers have also learned some important information. Thank you so much for being here and for all the great work that you do. And we'll catch
Thank
up.
you so much. It's been my pleasure, and I love all the great work you're doing too. So appreciate
Thank
it.
you. Okay, thank you. Have a great evening.
All right, you too.
Bye.
Bye.
Bye.